www. Plus I. Pediatric Orthopedics and Trauma Femoral Neck Abnormalities Management of Trauma Patients Blunt Trauma Penetrating Trauma Acute Limb Ischemia, Hair Tourniquet Syndrome, Developmental Dysplasia of the Hip Leg Calf Hertz Disease Slip Capital Femoral Epiphysis Juvenile Idiopathic Arthritis Osgood-Schlatter Disease Osteochondritis Dissecans Collection of Orthopedic Conditions, Genivalgum, Genivarum, Avascular Necrosis Spondylolisthesis Idiopathic Scoliosis Scheuermann Juvenile Kyphosis Foot Deformities Osteomyelitis Septic Arthritis Osteomalacia and Rickets Benign Bone Tumors at OA Home Library lists eye settings. Pediatric Orthopedics and Trauma Osteochondritis Dissecans FO Collection of Orthopedic Conditions, Genivalgum, Genivarum, OV, Avascular Necrosis Spondylolisthesis Idiopathic Scoliosis A, Scheuermann Juvenile Kyphosis Foot Deformities I'm Osteomyelitis *8 I'm Septic Arthritis *degree Osteomalacia and Rickets, A, Benign Bone Tumors plus I Pediatric Fractures plus I Clavicle Fracture A Humerus Fracture O Forearm Fractures A, Distal Radius Fractures, OU, Scaphoid Fracture Metacarpal Fractures, A, Child maltreatment equals 5 burns equals intravenous fluid therapy A Go A9 Home Library list settings. Femoral neck abnormalities are axial malalignments of the femoral neck involving the caput column diaphyseal angle and the femoral angle of anteversion. 4 common femoral version abnormalities are discussed here: coxivara, coxivalga, femoral anteversion, and femoral retroversion. Clinical features include an abnormal gait and pain with prolonged weight bearing. Some abnormalities may resolve spontaneously. However, severe cases require surgical correction. Common complications include secondary arthroses and femoroacetabular impingement. WA. CE. Overview. Scent definition: axial malalignments of the femoral neck involving the caput column diaphyseal angle, CCD angle, and the angle of anteversion M femoral neck axis, a line that equally divides the femoral neck through the center of the femoral head. Scent caput column diaphyseal angle, CCD angle, NL. Copyright the angle formed by the main axis of the femoral neck and the longitudinal axis of the femoral shaft, coxa norma, copyright normal angle 2. Equals 125 degrees in adults equals 150 degrees in newborns plus femoral anteversion angle /5, L4. Copyright the angle formed by the longitudinal axis of the femoral neck and the transverse axis of both femoral condyles of the distal femur. Copyright indicates the normal torsion of the femur. EO normal angle equals 8 to 15 degrees in adults equals 30 to 40 degrees in newborns. Scent Hilgen-Rainer epiphyseal angle, 5. Copyright the angle formed by the intersection of a line drawn from the triradiate cartilages, Hilgen-Rainer line, and another line drawn through the capital femoral physis O used to measure the severity of femoral deformities. EO normal angle, 25 degrees. Copyright femoral neck anomalies are initially diagnosed using plain X-ray. I. Coxivara. Scent definition: a deformity of the proximal femur due to a decreased femoral neck shaft angle. Overview of coxivara/5IL6 congenital developmental acquired. Plus present at birth * secondary to metabolic, neoplastic, or traumatic conditions * typically occurs with other skeletal deformities or as degree infection, example septic arthritis, osteomyelitis, leg calf Hertz disease osteopetrosis slipped capital femoral epiphysis, SCFE, fibrous dysplasia. Part of a syndrome degree. Copyright skeletal deformities degree. Spondyloepiphyseal dysplasia degree. Multiple epiphyseal dysplasia degree equals cleidocranial dysplasia develops during the perinatal period and may. Copyright Paget disease of bone. Etiology equals proximal femoral focal deficiency progress during childhood. Copyright vitamin D dependent rickets fibular deficiency degree. Trauma, example fracture of the femoral neck or trochanter, equals congenital short femur epiphyseal injuries. Copyright associated syndromes. Copyright vascular injury to the femoral growth plate, example * femoral facial syndrome avascular necrosis of the femoral head, equals camptodactyly arthropathy coxavara degree osteomalacia pericarditis syndrome copyright osteogenesis imperfecta. Scent unilateral involvement, typically in the subtrochanteric area, plus presents by walking age, 2 to 3 years of age, abductor muscle weakness * bilateral involvement _7 clinical scent limb length discrepancy, shorter leg on the affected * Trendelenburg gait. Clinical features of the undetailing disorder features side, * limited hip abduction and internal rotation * typically, unilateral involvement scent limb length discrepancy associated with, positive Trendelenburg sign, the hip is copyright femoral retroversion abducted when reduced. SQL. Collapse fine text outline. X femoral neck abnormalities. Unilateral involvement, typically in the subtrochanteric area, scent presents by walking age, 2 to 3 years of age, abductor muscle weakness scent bilateral involvement _ clinical plus limb length discrepancy, shorter leg on the affected * Trendelenburg gait degree clinical features of the underlying disorder features side, scent limited hip abduction and internal rotation * degree typically unilateral involvement scent limb length discrepancy associated with, positive Trendelenburg sign, the hip is copyright femoral retroversion abducted when reduced. Degree knee valgus. AP and lateral X-rays copyright reduced angle between femoral neck and shaft AP and lateral X-rays copyright vertically orientated and widened physis copyright triangular shaped ossification of the 3 * depends on the underlying disorder, example laboratory tests to degree overgrowth of the greater trochanter femoral neck. Diagnose rickets, vitamin D deficiency, diagnostics copyright small fractures may be present medially. Copyright changes in the femoral head and scent AP and lateral X-rays, reduced angle between femoral neck MRI acetabulum registered wider either B and shaft degree to assess the hip joint cartilage and labrum ICE OFME, Voices, copyright findings, widened physis, bone marrow edema, and *CT/MRI, pre-surgical planning expanded cartilage tissue. Plus expectant management. Copyright Hilgen-Rainer epiphyseal angle. Treatment * surgery, valgus derotation osteotomy, at the subtrochanteric or intertrochanteric level, I+ depends on the underlying disorder. Copyright progressive or severe deformities copyright symptomatic patients with a Hilgen-Rainer epiphyseal angle of 45°-60° a Hilgen-Rainer epiphyseal angle 60 degrees. * persistence of abnormal gait and functional impairment scent hip dysplasia CGIES * hip subluxation complications P+ premature closure of the femoral physis pseudoarthrosis scent osteoarthritis. 4. A. Oi. CE. Coxa-valga. Scent definition, deformity of the femur due to an increased femoral neck shaft angle, 140 degrees. Overview of coxa-valga, L. Congenital secondary. Low axial load scent seen in newborns or toddlers copyright neuromuscular disorders, example cerebral palsy, meningomyelocele, etiolo-sy possible genetic predisposition o skeletal dysplasias, example hip dysplasia, Turner syndrome, trauma leading to arrest of the growth plate. Usually asymptomatic typically bilateral groin pain due to long periods of weight-bearing limited hip abduction in some cases, a positive Trendelenburg sign. Depend on the underlying disease typically unilateral limited hip abduction positive Trendelenburg sign. Clinical features. Diagnostics AP X-ray of the hips, increased angle between femoral neck and shaft. Spontaneous normalization can be expected once skeletal development is complete. Physiotherapy treatment of underlying disease physiotherapy treatment persistent cases, varus derotation osteotomy, VDRO, surgical correction may be considered. Complications secondary arthroses. 7AQL. Collapse fine text outline. Femoral anteversion. Scent definition, a forward rotation of the femoral neck in relation to the femoral condyles due to an increased femoral anteversion angle MS plus epidemiology, 1L degree. Copyright occurs between 3 to 6 years of age, or more common in girls. Etiology. Copyright physiologic, present in up to 10% of children. Copyright congenital equals genetic predisposition, abnormal intrauterine position of the fetus. Copyright trauma, example femur fracture. Scent. Clinical features. Copyright typically bilateral hip extension. Abnormalities equals increased internal rotation equals limited external rotation. Copyright bowing of the legs. Copyright in towing gait. 1. Copyright hip or thigh pain, due to long periods of weight bearing. Copyright often associated with coxa valga. Diagnostics. Usually a clinical diagnosis based on physical examination findings. Copyright imaging equals X-ray equals CT/MRI. Scent. Treatment. Expectant management. In cases of physiologic anteversion usually resolves spontaneously by 10 years of age. Copyright surgery, intertrochanteric derotation. Osteotomy equals severe gait deformities equals symptoms that impair normal gait equals children 8 to 10 years of age with impaired gait. Scent. Complications, femoroacetabular impingement, an abnormal contact between the acetabulum and proximal femur during terminal hip flexion, which leads to damage of the articular cartilage and acetabular labrum. 10. Copyright toddlers that repeatedly or easily stumble may have femoral anteversion. Femoral retroversion. Scent. Definition, a backward rotation of the femoral neck in relation to the femoral condyles due to a decreased femoral anteversion angle. Plus etiology. LL2. Copyright physiologic. Copyright congenital equals genetic predisposition, abnormal intrauterine position of the fetus. Copyright trauma, example femur fracture. Scent. Clinical features. Usually bilateral. Usually late walkers. Hip extension. Abnormalities equals increased external rotation equals limited internal rotation. Copyright out towing gait. A. Copyright hip or thigh pain, due to long periods of weight bearing. Flat feet. Copyright often associated with tibial torsion equals AQL. Collapse. Find text outline. Expectant management equals in cases of physiologic anteversion equals usually resolves spontaneously by 10 years of age. Copyright surgery, intertrochanteric derotation. Osteotomy equals severe gait deformities equals symptoms that impair normal gait equals children 8 to 10 years of age with impaired gait. Scent. Complications, femorotabular impingement, an abnormal contact between the acetabulum and proximal femur during terminal hip flexion, which leads to damage of the articular cartilage and acetabular labrum. 10. Toddlers that repeatedly or easily stumble may have femoral anteversion. Femoral retroversion. Scent. Definition, a backward rotation of the femoral neck in relation to the femoral condyles due to a decreased femoral anteversion angle. A. Plus etiology. LL9. Copyright physiologic. Copyright congenital equals genetic predisposition, abnormal intrauterine position of the fetus. Trauma, example femur fracture. Scent. Clinical features. Usually bilateral. Usually late walkers. Copyright hip extension. Abnormalities equals increased external rotation, limited internal rotation. Copyright out towing gait. SY. Copyright hip or thigh pain, due to long periods of weight bearing. Flat feet. Copyright often associated with tibial torsion. Scent. Diagnostics. Copyright usually a clinical diagnosis based on physical examination findings. Copyright imaging equals X-ray CT/MRI. Scent. Treatment. Copyright orthotics. Physiotherapy. Copyright splinting or casting of the legs, to stretch and improve internal rotation. Copyright surgery, intertrochanteric derotation. Osteotomy *. Complications 0. Femoroacetabular impingement. Copyright hip osteoarthritis. Last updated March 14, 2023. Equals QL. Collapse. Find text outline. 140° coxa valga. Pound. $. SG. LE \K. \VO. Femoral neck abnormalities. Copyright Boss. Eurofemoral neck abnormalities, 2 halves. Femoral anteversion angle. Femur, left, anterior view, right, caudal view. The femoral anteversion, antetorsion, angle is the angle formed by the longitudinal axis of the femoral neck, A, and the transverse axis of the femoral condyles of the distal femur, B. This angle is usually around 815° in adults. Copyright on Boss. Urofemoral neck abnormalities, 1/2. Coxavara VV. Coxavara is a hip deformity in which there is a decreased angle between the femoral neck and shaft. Overlay. Coxavara VV. X-ray hip, AP view, the femoral neck shaft angle, caput column diaphyseal, CCD, angle, is reduced bilaterally, compatible with Coxavara. The angle on the right is measured as 110 degrees. Another finding of Coxavara, projection of the greater trochanter above the center of the femur head, dotted line and green overlay, is depicted on the left. Source, Coxavara 78JW, Row AP, 001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Femoral neck abnormalities, 2/2. Overlay. Coxavara VV. X-ray hip, AP view, the femoral neck shaft angle, caput column diaphyseal, CCD, angle, is reduced bilaterally, compatible with Coxavara. The angle on the right is measured as 110 degrees. Another finding of Coxavara, projection of the greater trochanter above the center of the femur head, dotted line and green overlay, is depicted on the left. Source, Coxavara 78JW, Row AP, 001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Urofemoral neck abnormalities, 1/2. 140 degree coxavalga. Coxavalga VV. Coxavalga is a hip deformity in which there is an increased angle between the femoral neck and shaft, 140 degrees. Copyright on Boss. S. Femoral neck abnormalities, 2/2. Overlay. Coxavalga. X-ray hips, AP view, of a 30-year-old male patient. The angle formed between the right femoral neck and shaft is abnormally increased, coxavalga, indicated by red lines and angle. The rotated left femur is not positioned for optimal angle measurement but shows the same abnormality. The right femoral head has subluxed laterally and shows a loss of sphericity, with flattening of the articular surface, indicated by white outline. There is bilateral superior joint space narrowing, red hatched overlay, and acetabular protrusion, green line, is present on the left. Additional radiographic findings include a gonad shield and a fixation device in the right femur. Source, copyright IMPP. S. Femoral neck abnormalities, 2/2. Copyright. Overlay. Coxavalga. X-ray hips, AP view, of a 30-year-old male patient. The angle formed between the right femoral neck and shaft is abnormally increased, coxavalga, indicated by red lines and angle. The rotated left femur is not positioned for optimal angle measurement but shows the same abnormality. The right femoral head has subluxed laterally and shows a loss of sphericity, with flattening of the articular surface, indicated by white outline. There is bilateral superior joint space narrowing, red hatched overlay, and acetabular protrusion, green line, is present on the left. Additional radiographic findings include a gonad shield and a fixation device in the right femur. Source, copyright IMPP. Femoral neck abnormalities, 1/2. Normal position. Femoral SZSAB. / neck axis 20 degrees. Increased femoral anteversion in towing. Equals FAIAL7 ALK. /F femoral IJ2. Anteversion SSY posterior angle 12 degrees $/J5 condylar axis degree, NAEAE, YOPA dash plus / SSSYS underscore EAA1 air / I EAEY AS SF underscore equals MNI / J, she. / out towing. Femoral anteversion and retroversion VV. Physiologically, the femoral neck is slightly anteverted in relation to the femoral condyles. Femoral anteversion angle between the longitudinal axis of the femoral neck and a transverse axis along the posterior aspects of the femoral condyles is 12 degrees in adults. If femoral anteversion is pathologically increased, anteversion angle 20 degrees, the femur is usually internally rotated to maintain the stability of the femoral head in the acetabulum, and the patient presents with in-toeing gait. If femoral anteversion is pathologically decreased, femoral retroversion, anteversion angle. Copyright Emboss. In-toeing VV. The feet/toes point medially. Source, In-toeing by Carl Wieman, Wikimedia Commons, licensed under CC by SA 4.0. Femoral neck abnormalities, 1/2. Normal position. Femoral SCSAB. / neck axis 20 degrees. Increased femoral anteversion in-toeing. Equals FAIAL 7 alk. /F femoral IJ2. Anteversion SSY posterior angle 12 degrees $/J5 condylar axis degree, NAEAE, YO PA dash plus / SSSYS underscore EAA1 air / I EAEY / AS / SF underscore equals MUNI I / J, she. / out-toeing. Femoral anteversion and retroversion VV. Physiologically, the femoral neck is slightly antevert in relation to the femoral condyles. Femoral anteversion angle between the longitudinal axis of the femoral neck and a transverse axis along the posterior aspects of the femoral condyles is 12 degrees in adults. If femoral anteversion is pathologically increased, anteversion angle 20 degrees, the femur is usually internally rotated to maintain the stability of the femoral head in the acetabulum, and the patient presents with in-toeing gait. If femoral anteversion is pathologically decreased, femoral retroversion, anteversion angle. Copyright Emboss. Urofemoral neck abnormalities, 2/2. Out-toeing. The feet/toes point laterally. Source, Out-toeing by Carl Wieman, Wikimedia Commons, licensed under CC by SA 4.0. X management of trauma patients. Trauma is one of the leading causes of death worldwide and, in the United States, the leading cause of death in young adults. Traumatic injuries range from isolated wounds to life-threatening multi-organ injuries. Advanced Trauma Life Support, ATLS, is a framework for the systematic evaluation of trauma patients to improve outcomes and reduce missed injuries. Pre-hospital trauma care involves life-saving interventions and basic life support in the field by emergency medical services while providing rapid transportation to the nearest appropriate hospital. In the hospital, the assessment of trauma patients begins with a primary survey in which life-threatening conditions are identified and treated using the sequential ABCDE approach. After the patient is stabilized, the secondary survey is performed, which involves a thorough history and physical examination as well as diagnostic testing to identify other injuries. The tertiary survey is performed within 24 hours of presentation to identify missed injuries. If at any point during the evaluation the patient's needs exceed the hospital's capabilities, the process to transfer the patient to a trauma center should be initiated. Trauma management of pregnant, geriatric, and pediatric patients requires additional considerations given their unique physiology. See also blunt trauma and penetrating trauma. OES. Definition. Plus Trauma Center. A health facility that provides specialized care to patients with serious traumatic injuries. Copyright different levels, example B, of trauma center can be designated, 1 cent trauma team. A multidisciplinary team that provides care to patients at trauma centers. Copyright consists of specialists from trauma surgery, emergency medicine, intensive care, and nursing. Members typically include a team leader, airway manager, assessment physician, proceduralist, trauma nurse, trauma technician, respiratory therapist, radiographer, and scribe. Plus Advanced Trauma Life Support, ATLS, 10A framework for managing patients with serious injuries in pre-hospital and hospital settings. Copyright describes management sequences, example ABCDE algorithm, that prioritize the most immediately life-threatening injuries first. O aims to standardize trauma care across centers with varying resources and experience with trauma management. Cent Polytrauma, severe injuries occurring in more than one anatomic region that cause systemic physiological disturbances to WA. FA. EXO. Overview. Trauma care varies based on patient injuries, receiving center resources, example equipment, consultants, and institutional and regional guidelines. Recommendations in this article are consistent with the 2018 Advanced Trauma Life Support Guidelines. Overview of ATLS. 1. Sequence of trauma care. 1. Pre-hospital trauma care and transportation to hospital. 2. Primary survey. 3. Transfer to trauma center, if needed. 4. Secondary survey. 5. Tertiary survey. Key components of ATLS. Overview of ATLS key components. Airway assessment with C-spine stabilization and airway management, breathing assessment with respiratory support and related procedures, circulation assessment with immediate hemodynamic support and hemorrhage control, disability assessment with TBI management and neuroprotective measures, exposure with environmental survey and hypothermia management, diagnostic adjuncts, example fast, portable CXR, transfer to trauma center, if needed. Primary survey. Treatment of traumatic cardiac arrest, if needed. Ample history head-to-toe physical examination. Secondary survey. Comprehensive diagnostic studies and imaging supportive care. Detailed history and physical to identify missed injuries. Tertiary survey. Additional diagnostics, if needed. Back collapse. Find text outline. Detailed history and physical to identify missed injuries. Additional diagnostics, if needed. Quality and safety measures. Tertiary survey. Pregnant individuals, see trauma during pregnancy and management of pregnant patients with trauma. Special patient groups. Older adults, see geriatric trauma. Children, see pediatric trauma. Overview of injury mechanisms. Overview of injury mechanisms. FL mechanisms of injury. Potential injuries. Motor vehicle collision. AOP, MVC, head, traumatic brain injury, facial fractures, thoracic, pulmonary contusions, cardiac contusions, rib fractures, pneumothorax, hemothorax, blunt thoracic aortic injury, fall from a height. Equals blunt trauma, diaphragmatic rupture, pedestrian struck, AAFF2. Abdominopelvic, splenic injuries, liver injuries, pelvic fracture, genitourinary trauma, bicycle crash, assault, musculoskeletal, spinal fractures, crush injury, lower extremity fractures. Neck, vascular injury, thoracic, cardiac tamponade, hemothorax, pneumothorax, diaphragmatic injury, abdominopelvic, hollow viscous perforation, hemorrhage, genitourinary trauma, musculoskeletal, neurovascular injuries, fractures, compartment syndrome. Stab injuries, penetrating T-col, SEIET, gunshot wounds, GSWs. Thermal burns, electrical injury, inhalation injury. Thermal burns, circumferential eschar, compartment syndrome, electrical injury, cardiac arrhythmias, myonecrosis, compartment syndrome, inhalation injury, airway swelling, pulmonary edema, carbon monoxide toxicity, thermal injury. Pressure-related injury, blunt trauma, penetrating trauma, burns. Pressure-related injury, barotrauma, blast lung, tympanic membrane rupture, blunt and slash or penetrating injury, due to flying debris, shrapnel, falls burns, thermal burns, inhalation injury, blast injuries. Exposure to toxic fumes. Drowning, cold-related injury, diving-related injury. Drowning, respiratory failure, cardiac arrest, cold-related injuries, hypothermia, frostbite, and non-freezing cold injuries, diving-related injuries, decompression disease, arterial gas embolism, barotrauma. Other environmental injuries. OOUR. FOSACS. Pre-hospital trauma care. Pre-hospital trauma care is situation-dependent and centered on field stabilization of the patient and prompt transport to the closest trauma center. Bystanders, IL3. Shout for help and/or call 911. Assess scene safety prior to providing assistance. Remove the patient from dangerous situations. Initiate basic life support, BLS. Perform life-saving interventions. Airway opening maneuvers. Hemorrhage control. Copyright spinal immobilization. Emergency medical services, EMS, L4I. CENT EMS typically perform an abbreviated version of the primary survey. CENT provide life-saving interventions. Airway management for respiratory distress or altered mental status. Hemorrhage control, example use of tourniquets or pressure bandages. Copyright immediate hemodynamic support, example for fluids. Prevent additional injury. Copyright spinal immobilization, example cervical collar placement, backboard, fracture stabilization. Provide parenteral analgesia, as needed. Rapidly transport the patient to the closest appropriate hospital. 4 FAY. OES. Primary survey. The ABCDE algorithm in ATLS provides a sequence to help prioritize treating the most rapidly life-threatening injuries first. In clinical practice, trauma team members NL. OIBA5s IFSZ% #ZF41AQL. Collapse fine text outline. X management of trauma patients. The ABCDE algorithm in ATLS provides a sequence to help prioritize treating the most rapidly life-threatening injuries first. In clinical practice, trauma team members evaluate and treat these simultaneously, continually reassessing each injury's severity throughout the resuscitation. U1. Airway, and C-spine stabilization. Identify and treat airway obstruction, example due to blood, direct injury, edema, and/or loss of airway protective reflexes, example due to AMS or coma, while preventing further C-spine injury. CENT assess the airway. Ask the patient to state their name. The ability to answer typically correlates with a patent airway. Evaluate for signs of airway compromise and signs of respiratory distress. Examine the airway for foreign bodies or injury, example facial fractures, SUD, burns. CENT perform initial interventions. Copyright suction oropharyngeal secretions and/or blood. Perform airway opening maneuvers. Copyright insert basic airway adjuncts. Plus intubate patients with airway obstruction and/or respiratory failure depressed mental status, example GCS. Copyright immobilize the cervical spine with a cervical collar. Manually stabilize the cervical spine during airway management. Perform cricothyrotomy in case of intubation failure. Copyright consider early intubation for impending airway obstruction in patients with signs of inhalation injury, moderate to severe facial and oropharyngeal burns, and extensive body burns. 8. Breathing, 1. Identify and treat chest injuries, example tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, and tracheobronchial injuries. Assess oxygenation, evaluate SPO, and start continuous pulse oximetry. CENT assess ventilation. Copyright vital signs, monitor rate and quality of respirations. Copyright neck, inspect for jugular venous distension and tracheal deviation. Copyright chest, auscultate and inspect for chest wall injuries, example penetrating wounds, subcutaneous emphysema, absent breath sounds, paradoxical chest movement. Copyright consider EFAST to help identify pneumothorax at the bedside. CENT perform initial interventions. Copyright supplemental 020 emergency chest decompression for suspected tension pneumothorax. Copyright 3-sided dressing for sucking chest wound OBMV or mechanical ventilation for respiratory failure. Copyright if traumatic pneumothorax is suspected in a patient requiring positive pressure ventilation, perform tube thoracostomy immediately to prevent progression to tension pneumothorax. 1. Circulation. Provide immediate hemodynamic support and hemostatic measures while identifying sources of bleeding, example external hemorrhage, thoracic cavity, abdominal cavity, thighs, retroperitoneal space. E. Assess hemodynamic status. O. Assess central pulses, level of consciousness, and capillary refill time. Copyright monitor vitals and continuous cardiac telemetry. CENT perform initial interventions. Copyright place 2 large bore IVs, at least 18 gauge. E. Consider intraosseous access if peripheral 4 cannot be obtained. EO. Administer 1L warmed isotonic crystalloid bolus. Copyright if unresponsive to 4 fluid, proceed to blood transfusion. Localize hemorrhage. O. Perform fast to rapidly identify hemopericardium, and intrathoracic, intra-abdominal, and /or intrapelvic bleeding in unstable patients. Copyright identify obvious pelvic or long bone, example femur, deformity. 1. Copyright identify major bleeding vessels, example in the neck, groin, chest, or proximal extremities. O. Identify indications for immediate surgery, example exploratory laparotomy, urgent thoracotomy, and /or angioembolization. CENT treat hemorrhagic shock. O. Administer emergency transfusion with universal donor blood products, example type O blood, if required. WV equals AL. Collapse fine text outline. CENT treat hemorrhagic shock. E. Administer emergency transfusion with universal donor blood products, example type O blood, if required. E. Provide cross-matched blood products as soon as they are available. Copyright follow local massive transfusion protocol if indicated, example plasma, platelets, and PRBCS at a 1:1:1 ratio. Copyright consider tranexamic acid, TXA. J. OLL 11 Copyright consider reversal of anticoagulation. Copyright allow for permissive hypotension. CENT perform bedside hemorrhage control. O. Apply pressure or tourniquet to control active external hemorrhage. E. Apply pelvic binder for suspected bleeding pelvic fractures. O. Insert chest tube for suspected massive traumatic hemothorax. Treat obstructive shock, example chest tube insertion for tension pneumothorax, pericardial window for cardiac tamponade. Copyright if there is a loss of vital signs, treat traumatic cardiac arrest with emergency chest decompression and emergency thoracotomy. Suspect cardiac tamponade in patients with penetrating chest injury with Beck triad and a positive FAST scan, and expedite urgent pericardial fluid drainage via thoracotomy. E. Penetrating abdominal injury with signs of shock is usually an indication for exploratory laparotomy. Disability. Identify life-threatening traumatic brain injury, TBI, begin measures to limit secondary brain injury, and expedite definitive surgery if indicated. CENT perform rapid neurological evaluation. Copyright calculate CS. Copyright assess pupillary light response. O. Assess motor and sensation functions. Initiate TBI management. Copyright consult neurosurgery. Copyright start neuroprotective measures. Copyright start ICP management if a cerebral herniation syndrome is present. Registered remain vigilant for signs of traumatic brain injury in intoxicated patients. 1. Catcutate triquid. Exposure, and environmental control. E. Undress the patient completely. Examine the entire patient for signs of occult injury, including the axilla, groin, and back. CENT prevent and /or manage hypothermia with revarming techniques. Traumatic circulatory arrest. 1. CENT common causes include tension pneumothorax, cardiac tamponade, and hemorrhagic shock. Management. Copyright first line, bilateral chest decompression with finger thoracostomy. Copyright consider emergency thoracotomy. A. Resuscitative thoracotomy, 121. Definition: a bedside procedure performed in the emergency department or trauma bay to obtain emergency access to the thoracic cavity to provide temporizing life-saving measures in pulseless patients. Indications: O pulseless patients after penetrating thoracic injury. O pulseless patients after penetrating extrathoracic injury, excluding isolated cranial injuries. Copyright pulseless patients with recently documented signs of life in the field or at the hospital after blunt injury. Degree C. Indication: pulseless patients without any documented signs of life in the field or at the hospital after blunt injury. SQL. Collapse. Fine text outline. Secondary survey. The secondary survey is performed after the patient is stabilized, and it involves a thorough history and physical examination as well as diagnostic testing to identify other injuries. History. 1. Obtain the following to anticipate likely injuries and estimate patient's physiological reserve. Sent ample history, a focused history approach recommended in the rapid evaluation of patients with trauma. Copyright allergies. Copyright medications. O past medical history and pregnancy status. O last meal. O events and environment related to the injury. E mechanism of injury. Copyright injury patterns can provide clues to the mechanism of injury, example direction, amount of energy. Copyright commonly divided into blunt trauma and penetrating trauma. C. Blunt trauma injury mechanisms. C. Gunshot injuries and penetrating trauma. Obtain collateral information from EMS, family, and/or witnesses, especially if the patient is unable to provide a reliable history. Physical examination. A systematic head-to-toe physical examination must be completed to identify additional injuries. Assess each body part for open wounds, lacerations, abrasions, foreign bodies, and/or bruising. Identify any bony deformities, areas with focal tenderness, or edema. Document all findings. Further management. Provide tetanus prophylaxis for open wounds. If intraperitoneal injury is suspected, administer empiric antibiotics for intra-abdominal infections. OOES. Tertiary survey. Goal 1113. Identify injuries undetected during primary and secondary surveys. Ensure patient safety. Complete the tertiary survey within 24 hours of presentation. A standardized tertiary survey with high-quality imaging may limit the incidence of missed injuries. 14. Approach, 1I13. Identify and rectify gaps in the patient's medical history, example chronic conditions, medications, allergies. Repeat examination of the patient focusing on musculoskeletal injuries and detailed neurovascular examination. Review previously obtained diagnostic studies. Order additional studies based on tertiary survey findings. Hand and foot injuries are the most common missed injuries. 151L16. GP-UR. AE. Diagnostics. Approach. Consider clinical judgment, mechanism of injury, and patient factors, example age, hemodynamic status, when choosing diagnostic studies. Weigh the need and timing of diagnostic studies against the need for urgent interfacility transfer or surgical intervention for each patient. ECC 111. Indications, mechanisms that may result in cardiac injury, example in blunt chest trauma, findings equals, AO. Collapse. Fine text outline. ECG, Yen. Indications, mechanisms that may result in cardiac injury, example in blunt chest trauma, findings. Copyright blunt cardiac injury, example dysrhythmia, ST segment changes, copyright pericardial effusion and cardiac tamponade, example electrical alternans, low voltage QRS. Laboratory studies. Routine studies, CBC, BMP LFTs. Preoperative studies, coagulation studies, type, and screen pregnancy test, example serum or urine BHCG, POC glucose scent urinalysis, see approach to genitourinary trauma for details. Lactate ABG, to evaluate P0, PCO, pH and base deficit. Copyright normotensive patients with trauma may have subclinical hypoperfusion. Evaluate for other clinical features of shock and check hemodynamic parameters, example serum lactate, base deficit. FAST and EFAST, 11I20. See point of care ultrasound, POCUS, for procedural details, example image generation and troubleshooting. Focused assessment with sonography for trauma, FAST thoracoabdominal POCUS used in trauma patients to detect free fluid within the peritoneal, pericardial, and pleural cavities. Extended FAST, EFAST, an extension of the FAST scan that includes evaluation of the chest for lung sliding scent. Clinical applications in trauma. Copyright can identify internal hemorrhage, example hemoperitoneum, hemopericardium, hemothorax, requiring operative intervention in unstable patients. OEFAST can additionally help identify pneumothorax. Used primarily as a diagnostic adjunct during the primary survey scent technique. Sonography of the subxiphoid, RUQ, LUQ, pelvic, and anterior thoracic regions is typically performed. See FAST and EFAST in POCUS for details. Scent findings, see FAST and EFAST in POCUS for details. Free fluid can be seen in the following spaces, equals pericardial equals pleural equals hepatorenal equals sphenorenal and / or subphrenic equals pelvic. Copyright lung sliding may be absent in pneumothorax. Copyright interpret FAST and EFAST alongside other diagnostic parameters and clinical judgment. POCUS does not replace definitive diagnostic studies. 20. A positive FAST exam in a hemodynamically unstable patient with trauma is usually an indication for urgent operative intervention, example exploratory laparotomy, copyright urgent thoracotomy, pericardiotomy. Bedside chest and pelvic X-rays are commonly performed during the primary survey, while extremity and spine X-rays are typically reserved for the secondary survey. And freetate in hepatorense low free fluid in ionorenst pericardial effusion main phone A. Radiography, 1. CXR. Scent indications, blunt or penetrating trauma to the chest or abdomen. Findings: O pneumothorax, O hemothorax, O pneumoperitoneum, O pneumomediastinum, O widened mediastinum. Pelvic X-ray. Scent indications: 7Q-Al. Collapse fine text outline. Pelvic X-ray. Scent indications: O blunt or penetrating trauma to the abdomen, O unstable pelvis. Scent findings: pelvic fracture. Extremity X-rays. Scent indications: pain, redness, swelling, or deformity at the injury site. Findings: fracture and / or dislocation. Spinal X-rays. Spinal X-rays have been replaced by CT imaging in most trauma centers. Scent indications: copyright spinal tenderness to palpation, copyright disruption of the vertebral process alignment, i.e., step-off deformity, extremity numbness, tingling, or weakness, neurogenic shock. Findings: O vertebral compression fracture, burst fracture, copyright chance fracture, copyright transverse process fracture, O spinous process fracture, copyright spondylolisthesis. CT imaging in trauma. Approach: perform CT scans preferentially during the secondary survey in hemodynamically stable patients with no obvious indications for emergent laparotomy. Avoid transporting unstable patients out of resuscitation areas to obtain CT scans whenever possible. Whole body CT, PAN scan, 21. May be performed to evaluate patients with multiple injuries after significant trauma. Scent commonly includes Copyright CT head without 4 contrast. Copyright CT cervical spine without 4 contrast. Copyright CT thoracic and lumbar spine with 4 contrast. Copyright CT chest with 4 contrast. OCTA chest OECT abdomen and pelvis with 4 contrast. CT head and spine. Sent CT head without 4 contrast. See diagnostic imaging in traumatic brain injury. Sent CT cervical spine without 4 contrast. Copyright indications * clinical suspicion of C-spine injury based on mechanism and examination. Inability to clear C-spine clinically using a validated tool, example Nexus C-spine criteria, Canadian C-spine rule, CCR. 5. Copyright findings equals bony deformity and / or fracture of the vertebral body or processes equals loss of alignment of the vertebral bodies equals increased distance between vertebrae equals narrowing of vertebral canal equals increased prevertebral soft tissue swelling * CT thoracic and lumbar spine without 4 contrast. Copyright indications, clinical suspicion of T-spine and / or L spine injury based on mechanism and examination. Copyright findings, similar to CT cervical spine. Consider imaging for spinal fractures in patients with evidence of high-energy trauma to the lower extremities, example calcaneus fracture, after falling from a height. Copyright obtain CT cervical spine if C-spine injury cannot be ruled out using validated clinical decision tools. 26. Catautate by Ox MD, Catate TIQ EMD. Collapse fine text outline. CT chest with 4 contrast 271 I-28. Sent indications copyright inability to rule out blunt chest trauma with validated clinical decision tools. A copyright penetrating chest trauma. E findings copyright cardiac injury, example blunt cardiac injury, copyright lung injury, example pneumothorax, hemothorax, pulmonary contusion, copyright tracheal injury. E diaphragm injury. O esophageal injury. Copyright chest wall injury, example rib fracture. CTA chest. Sent indications copyright inability to rule out blunt chest trauma with validated clinical decision tools. FF copyright penetrating chest trauma with concern for great vessel injury. Sent findings copyright cardiac injury, example blunt cardiac injury, copyright blunt thoracic aortic injury. O vascular injury, example penetrating chest trauma, 2 degrees. Consider CTA chest to evaluate for blunt thoracic aortic injury in patients with high energy trauma and a wide mediastinum on CXR. CT abdomen and pelvis with 4 contrast. Sent indications copyright blunt and / or penetrating abdominal trauma. Copyright penetrating back and / or flank trauma with no other indications for immediate laparotomy. Sent findings copyright stomach injury. Copyright splenic injury, example splenic rupture. O liver injury, example liver hematoma. Copyright small and large bowel injuries, example gastrointestinal perforation. Copyright kidney injury, example renal laceration, renal hematoma. Copyright bladder injury, example rupture of the bladder. Copyright pelvic fracture. Diagnostic peritoneal lavage, DPL. Sent definition, an invasive diagnostic test used to assess for hemoperitoneum or viscous perforation in abdominal trauma. * indications, may be performed after the primary survey for suspected hemoperitoneum with equivocal or unavailable fast procedure. A catheter is placed into the abdomen and contents are aspirated to assess for the presence of blood or fecal matter. If neither is observed, a liter of warm saline is instilled and then collected for cytological analysis. Findings: the presence of bile, fecal matter, or equals 10 cubic centimeters of blood is considered a positive test and is an indication for emergent laparotomy. Ancillary testing. Additional testing may be performed depending on the mechanism of injury and clinical evaluation, and may include bronchoscopy for tracheobronchial injury, esophagoscopy for esophageal perforation, assessment for features of GU trauma, example using CT urography, retrograde urethrogram for renal, ureteral, and urethral injuries, sent echocardiography for blunt cardiac injury. Copyright assess patients for features of GU trauma, example with retrograde urethrogram, if there is hematuria, blood at the meatus, inability to void, need for pelvic binder, scrotal hematoma, or perineal ecchymosis. Add. Suspect tracheobronchial injury in patients with extensive subcutaneous emphysema. OX. Special patient groups. Trauma in pregnant individuals. Cent epidemiology 30 copyright incidents, every 72th pregnant woman experiences trauma. Copyright trauma in pregnancy is the leading cause of non-obstetrical maternal death in the U.S. AQL. Collapse fine text outline. Asterisk etiology 31182. Copyright unintentional trauma, example due to falls, MVCs, copyright intentional trauma, equals intimate partner violence equals assault equals suicide attempt asterisk classification 3 copyright minor trauma, 90% trauma for which obstetrical surveillance suffices 1. Equals no abdominal involvement equals no rapid compression or deceleration equals no pain or vaginal bleeding no loss of fluid normal fetal movement O major trauma, 10% trauma that requires further assessment in a trauma center abdominal involvement with abdominal pain equals signs and symptoms of internal bleeding equals hematuria vaginal bleeding and / or loss of fluid loss of consciousness rapid compression and / or deceleration equals decreased fetal movement. Overview of trauma in pregnancy maternal fetal vaginal bleeding asterisk hematuria asterisk abdominal pain asterisk premature labor rupture of membranes. Fetal heart rate changes decreased fetal movement clinical features. Clinical evaluation, see primary survey, laboratory studies, rhesus blood type, to avoid maternal Rh alloimmunization, diagnostics degree imaging copyright ultrasound. Doppler ultrasound, detection of fetal heartbeat assessment of the gestational age FA electron. Special patient groups. Trauma in pregnant individuals. Cent epidemiology 30 copyright incidents, every 72th pregnant woman experiences trauma. Copyright trauma in pregnancy is the leading cause of non-obstetrical maternal death in the U.S. AQL. Collapse fine text outline. Asterisk etiology 31182. Copyright unintentional trauma, example due to falls, MVCs, copyright intentional trauma, equals intimate partner violence equals assault equals suicide attempt asterisk classification 3 copyright minor trauma, 90% trauma for which obstetrical surveillance suffices 1. Equals no abdominal involvement equals no rapid compression or deceleration equals no pain or vaginal bleeding no loss of fluid normal fetal movement O major trauma, 10% trauma that requires further assessment in a trauma center abdominal involvement with abdominal pain equals signs and symptoms of internal bleeding equals hematuria vaginal bleeding and / or loss of fluid loss of consciousness rapid compression and / or deceleration equals decreased fetal movement. Overview of trauma in pregnancy maternal fetal vaginal bleeding asterisk hematuria asterisk abdominal pain asterisk premature labor rupture of membranes. Fetal heart rate changes decreased fetal movement clinical features. Clinical evaluation, see primary survey, laboratory studies, rhesus blood type, to avoid maternal Rh alloimmunization, diagnostics degree imaging copyright ultrasound. Doppler ultrasound, detection of fetal heartbeat assessment of the gestational age FA electronic fetal monitoring, minimum 4 hours detection of fetal distress, placental abruption and preterm labor copyright X-ray, CT scan, should not be deferred because of fetal radiation concerns, 7 PA. Minor trauma, obstetric surveillance minor trauma, obstetric surveillance Cent major trauma management plus major trauma, initial stabilization and resuscitation of the mother as needed, further copyright intrauterine resuscitation of the fetus assessment in trauma center, see primary survey, copyright perimotum cesarean section, in case of viable fetus 23 weeks gestation after unsuccessful maternal resuscitation for 4 to 5 minutes. Complications. Copyright due to physiological changes during pregnancy. Superior displacement of abdominal organs equals increased risk of gastrointestinal injury from chest or upper abdominal trauma equals increased risk of aspiration during intubation. Decrease of blood pressure by 15 to 20 mmHg only during 2-4 trimester. Increased risk of hypotensive complications, example falls due to syncope, and missing pathological causes underlying hypotension. Increase of the heart rate by 15 to 20 bpm only during 3 degrees trimester. Increased risk of complications from tachycardia, example arrhythmias, and missing pathological causes underlying tachycardia equals increase of blood volume, increased risk of overlooked blood loss. Copyright placental abruption and preterm labor o fetal loss, 60 to 70% caused by minor trauma, with placental abruption being the most common complication. Copyright supine hypotensive syndrome following trauma, see supine hypotensive syndrome. In other complications below, O uterine rupture and exsanguination. O maternal death. Scent prevention. Copyright screen all pregnant women for intimate partner violence. For more information see intimate partner violence. Avoid examining the mother in the supine position in order to avoid possible supine hypotensive syndrome. Copyright the mother should be evaluated and treated before the fetus. Early and optimal diagnostics and trauma management of the mother is the best treatment for the fetus. SCES. Tips and links. Sources: AQL. Collapse fine text outline. Euro management of trauma patients, 1/1. Emergency thoracotomy. Euro management of trauma patients, 7/8. _ 4, / Woo. EFAST, placement of the transducer. 1. Right upper quadrant. Place the transducer over the right anterior axillary line along the subcostal margin or over the inferior intercostal spaces. Angle the transducer superiorly to assess the right costodiaphragmatic recess and right subphrenic space, and inferiorly to assess the hepatornal space and inferior pole of the right kidney. 2. Left upper quadrant. Place the transducer over the left mid-axillary line in one of the inferior intercostal spaces. Angle the transducer superiorly to assess the left costodiaphragmatic recess and left subphrenic space, and inferiorly to assess the sphenorenal space and inferior pole of the left kidney. 3. Subxiphoid. Place the transducer in the subxiphoid space and tilt it up and toward the left shoulder to assess the pericardial space. 4. Pelvic. Place the transducer just above the pubic bone to assess the rectovesical space, 0, or rectuterine space, 2. Obtain transverse and longitudinal views. Management of trauma patients, 8/8. EFAST, main areas of interest. VV. 1. Right upper quadrant. Right costodiaphragmatic recess hepatornal space. 2. Left upper quadrant. Left costodiaphragmatic recess sphenorenal space. 3. Subxiphoid, pericardial space. 4. Pelvic dollar rectuterine space and rectovesical space, not shown here.